Good morning, everyone. Thank you for joining me at another Wellness Wednesday episode. I am thrilled to have with us for Lung Cancer Awareness Month Dr. Tiffany Schatz from Lumiri Surgical. She is the owner and founder of the practice, and she specializes in thoracic, abdominal, and digestive. Um, Neoadjuvant, adjuvant, and palliative surgery utilizing minimally invasive techniques. And so I'm thrilled again to have us back with us in this discussion for this month. And without further ado, I want to get diving into this topic. So I'm going to bring her on. Good morning, Dr. Schatz. How are you?
Good morning. I'm wonderful. How are you?
Wonderful. Look at this bright sunshine. I can't complain.
Agreed.
So, tell us a little bit more about yourself, the practice. I know I gave a brief, introduction about you. If you could just, give us a little bit about yourself.
Yeah, I am a solo practice surgeon in Southeast Pennsylvania. I take care of mainly lung cancer and paraesophageal hernias uh, and general thoracic surgery. So it's very rewarding. I love to do robotic surgery, and my patients come from sort of a wide variety of backgrounds, and that I've been doing this in this area for about 5 years, and then I was in Maryland before. So this is actually our home ground. So we came back from Maryland to where my husband and I grew up, and we're happy to be here.
Well, welcome back and welcome home. So, nice to have you here in Pennsylvania.
Thank you.
So let's start with the question of are there any screening updates for lung cancer? What are some of the common comments that you've heard from patients regarding lung cancer screenings?
So, lung cancer screening is a test that has been done using low dose CT imaging of the chest, looking for small lung cancers that haven't shown any symptoms yet. And basically, the reason is that once we discover lung cancer after it started showing symptoms, it's usually advanced and much more difficult to treat and has a much higher mortality or risk of death. So, what we have found is that in smokers, people who have smoked a longer period of time, usually more than 20 pack years, which is about a pack a day for 20 years or more, um, then those people will benefit from having a CT scan to evaluate for a small asymptomatic growth. And this can actually decrease the risk of dying from lung cancer by 20%, which is a better odds than the improvement by mammogram for breast cancer, colonoscopy for colon cancer. So it's a very high value screening test.
Do you see, should we improve on that? Is there, should there be more awareness in terms of the, low dose screening cancer screening test? Because I'm not sure if most people really get to hear a lot of the advocate for that.
Right.
And aside from the tobacco smokers, is there any other in the population that should also get it as well? Just as anything, I liken it as your preventive measures, and that if there's any other testing or a particular age, so to speak.
Right. So the low dose CT screening test is right now just for smokers who have continued to smoke up until recently, with the most being 15 years quitting. 15 years ago, if you quit, then you're not eligible anymore. But anybody else age 50 and over who has a long-term history of smoking should have this screening test. And that does make it more difficult for us to get the word out because, for example, with mammogram, all women over 40 should have it. With colonoscopy, all people over 50 or or people with family history should have it, um, or some family history earlier. But essentially, with smoking, we don't have that catch-all basket.
Mm,
So the patients have to be self-identified or identified by their physicians, and so it takes an extra step. So in Philadelphia, a couple of years ago, the stats were that about 75% of women were getting their mammograms, less than 50% were getting their colonoscopy,
mm,
and our estimate is that less than 5% of lung cancer screening potential patients are getting their screening test.
mm,
So it is one that it's recommended that if you think you may fall into that category, you should ask your physician, your primary care, your pulmonologist, to assess whether you're appropriate for that test and order it. It's a test that should be done yearly for somebody who has that kind of smoking history.
mm,
And it's only done for people who don't have symptoms. So if you're having a symptom, we're diagnosing something, right? If you
mhm.
don't have symptoms, then we're looking for a new finding that we can treat early.
Is there any way that a patient can reduce the risk of developing lung cancer, or is that's my general question? Is there something that can be actively done, or
Absolutely. The biggest thing is to quit smoking. So it's one of the hardest things to do. I know. I mean, I see patients every day who have been long term smokers who have tried 3 and 4 times to quit smoking. But quitting smoking is the biggest thing that you can do to reduce your risk of developing lung cancer. Even if you've been a long term smoker, your risk reduces. Even if you've had lung cancer before, your quitting smoking will reduce your risk of getting a second lung cancer. So that would be the biggest thing. Um, but obviously, there are other things that can help contribute to lung cancer, um, such as other toxins in the environment, and so um, using precautions when dealing with those kind of environmental toxins, it would be helpful, like wearing a mask and when working in construction or doing that kind of thing. But lung cancer is has a greatest risk with smoking. Now that doesn't mean that you can't get lung cancer if you're a non-smoker,
Mhm.
but I don't have a magic pill to prevent it from happening.
Got it. You actually answered my questions because that was the other one I was thinking about. What about the non-smokers or folks that happen to be with or live with someone that does smoke, or be in an environment where they do are exposed to those things. So, when a patient gets diagnosed with lung cancer and they're referred to you, what's your evaluation, your assessment? How do you take through the process when the patient has been, and so coming to you, looking to get the treatment or looking to find a way to navigate through that. I think when you hear the diagnoses and when it can be scary and it can also have, some anxiety attached to it. So walk me through in that way, what your processes are.
Right. It can be very anxiety provoking and confusing. And a new lung cancer does require a lot of testing and evaluation, and a lot of times referral to multiple different physicians. So it
Mm,
is very helpful to have a navigator and at least a family member to help kind of walk with you through these kind of medical experiences. But the first thing that we do typically is the identification on the screening test or a CT scan, sometimes done for another reason. That's, maybe an abdominal CT for another reason or a chest x ray for another complaint. And when the lesion is picked up, then the first thing that we want to do is to take a look at how concerning is it? If it's very concerning for probable lung cancer, then we often do multiple of the evaluation steps at the same time. So if we're concerned that something is a lung cancer, we will want to do a PET scan. A PET scan is a sugar scan that helps to show how active or how quickly the tissue is growing. And that helps to let us know, is this something that has been there, is not been active for a long time, maybe scar tissue, that kind of thing? Or is this something that's growing, using a lot of sugar, and like a cancer, getting bigger? Um, the other thing that we would want to do is a biopsy, if at all possible. So, oftentimes, a biopsy can be done through the chest wall with a needle using a CT scanner, and that's usually done by a radiologist, a special radiologist. Another way that we can biopsy is through the airway. Um, there are special tests that bronchoscopy can target the lesion. That's usually done by a surgeon or a pulmonologist, a specialized pulmonologist. So those are the first tests. Once we identify that the lesion is cancer, then we have additional tests for evaluating whether the patient can be treated, and in what way. So the PET scan helps us to screen, or to stage the patient as far as, is that tissue that's lighting up, is it only in the lesion, or is it also in the lymph nodes, or has it spread to other places in the body? And then we evaluate the brain as well with an MRI typically, because the brain is always using a lot of sugar. So the PET scan does not really help us in identifying spread to the brain. So once we've decided what stage the cancer is, whether it's stage 1 or 2 and can be treated with surgery and potentially chemotherapy, whether it's stage 3 and maybe needs chemotherapy and radiation and with possible surgery, or whether it's stage 4 and can only be treated with chemotherapy and possibly other newer therapies like immunotherapy. Um, that determines the next steps, right? Once you have those, you can decide, is this patient potentially a surgical candidate? If the patient can potentially be a surgical candidate from the cancer, then we have to decide if the patient themselves can undergo surgery. So we have to evaluate a couple of key things. One is the lung function, and second is the heart function, or the general medical condition. So that those are the main steps. If a patient is not a candidate for surgery, then radiation is another option for an early stage lung cancer.
So it sounds like there's some multidisciplinary parts of this care team that includes
Yes,
you,
quite a big team. Mm-hmm.
and it's quite a big team that the patient is at the center, but in all of that there's also surrounded by other multidisciplinary teams that coordinates the care in relationship to the lung cancer identified, whether they're stage 1 or stage 2. So, so let's fast forward a bit here in the next question, in the way of, they've had their surgery, they were, a good candidate, they've had that. And so post surgery, what is the expectation? What, obviously each patient is different, in their recovery. No one is alike. Having said that, what would be then, sort of post-operatively, the frequency of when they were to see you, and then what are some annual, things that they would do, post surgical, once they're done that, and then what is your cadence then thereafter, as far as like touch points and so on.
Right. So once a patient has been treated surgically for lung cancer, and if they're not a candidate for chemotherapy or any additional treatments, I will follow them usually every 6 months with the CT scan of the chest to evaluate for any possible recurrence of the cancer. And that we do for 2 years after the surgery. And then after that, we do a CT scan with an evaluation every year for up to 10 years after the cancer diagnosis. And that is to make sure that there's no changes in the local area where the cancer was removed, the lung tissue, and also in the lymph nodes or anywhere else in the body that those in the chest mainly that nothing else springs up. And so I do have a long-term relationship with my patients, which is really wonderful as a surgeon to have kind of both aspects. And so I also tell my patients that this is routine until it isn't, right?
Mm-hmm.
Once we find something abnormal, then we have to kind of go back and do more testing and figure out what is it that we've seen. Likewise, if a patient has new symptoms, they have a new cough or blood coming, bloody sputum, or they're, have new weight loss or these kind of things, then they can have an evaluation sooner. I want to see them. I want to hear about it. I want to go ahead and do the next step of testing. So it's a regular cadence every 6 months for the first 2 years and every year after that, but with the option to increase evaluation as needed.
So you mentioned that if they do get chemotherapy and so on, where are you in that spectrum of the care team? If they do end up having chemotherapy or radiation and so on, what's that cadence then? Seeing that they have additional appointments.
Right. If a patient's already had their surgery with me, I'm often a backup person. So, a lot of times, because of the strong relationship that I build with the patients, they often need reassurance or guidance from someone they trust. And I am a lot of times someone that becomes that early in the treatment course. So oftentimes patients will come back to me with symptoms, even if they've been seen by other doctors, because they want me to do the follow-up evaluation. Once they need the chemotherapy or radiation, I can put in Portacath for chemotherapy administration, which is a little button that goes under the skin. It allows the chemotherapy to be put directly into the bloodstream without needing to do, an IV every time and so forth. But that's a pretty minor procedure comparatively to the lung cancer surgery. So at that point, I'm really a support person. And so oftentimes when people are getting chemotherapy or radiation, they don't need to come back and see me. Every once in a while, um, they still will check in with me. But usually I will see them after they finish their chemotherapy and radiation, after what we call restaging, where we redo the PET scan, redo the CAT scan after the chemotherapy and radiation and see what where are we now? What do things look like? Sometimes it does change our next course of treatment. And sometimes we find that we need to do additional care. Sometimes people develop pleural effusions, which is fluid around the lung, or other problems, which I can help with. But like I said, at this point, I'm more of a support person than guiding the care.
Got it. So I didn't get to ask you this question. What led you or what got you interested in the specialty that you're in as a surgeon, particularly with lung cancer? What is it about, this particular uh, diagnoses, if you will, really, brought your interest? And I'm sure there's other interests as well. Please let me know. But what got you really passionate about this part of care? And what are some of the things that you're seeing with your patients that you've worked so far, and their outcomes?
Yes, well, I love to operate. I'm a surgeon, so I really enjoy doing procedures. Thoracic surgery and lung cancer is very rewarding. Um, when we can remove a major cancer that has high risk and the patient can be cancer free afterwards. That is extremely rewarding. Um, I also, I mean, it's beautiful. It's beautiful to be in the chest and to see the heart beating and to see the lung expanding once we've finished the procedure and we fill it back up with air. It's beautiful. I think that it's such a vital area in the body, and it's very um, gratifying to see it and to have patients do well. As far as the patients themselves, I have fantastic patients who oftentimes are older because cancer does develop usually over decades.
Mhm.
So
Mhm.
it's oftentimes older patients, and I love working with patients who have so many different experiences, and um, I love to care for them in this moment of crisis when they need guidance, reassurance, education, and just somebody who's in their corner to make sure that we don't drop the ball on their care. And I really love to be a part of that.
It sounds like there's an old, you mentioned, and if I'm listening to what you're saying, there's an older population that you have in terms of, folks that have been seeing you as patients. Is there, and perhaps this could be a phase two, in a conversation, is there a different approach when you have a more older patient, and respectfully more of a senior population in that kind of way, when they come to you? Is there a different methodology? Is there a different approach? What was that look like from that uh, population health of older patients?
Yes, we do have to take into account that patients that are older sometimes are deconditioned. Sometimes, if they do have multiple medical problems, that can cause their treatment course to be more complicated. So, we do evaluate them with their cardiac function, their heart, how their heart is functioning, and their lung function, but also, how do they move around? Are they able to do exercise, physically? Are they going to be able to rehab themselves after surgery? Or are they going to get more weak and not bounce back? We are fortunate to live in a time when we can do minimally invasive surgery, and not the big thoracotomy that we had to do previously for lung cancer. So patients even into their 80s can often qualify for these kind of um, lobectomies, lung cancer surgery, in order to be cured from lung cancer. When previously, I think it would have been a little bit more um, risky to put a patient through surgery um, with with those kind of morbid procedures. So that being said, we are actually doing more surgery on elderly patients than previously, but we do have to be very careful because it is a big surgery. It's a major surgery to have any kind of surgery in your chest. So we often would recommend, even for older patients, to do what's called prehab. Now, prehab, it sounds like rehab, but it's actually before the surgery. So to improve patients' activity level and improve their function, even by regular exercise and by nutrition, improving their protein intake and so forth. Doing things like stopping smoking, which is a huge thing as well. But the prehab can help patients, especially older patients, who tend to lose their function faster after surgery, to have a better outcome by building up beforehand so that when they lose some after, they can still recover from the major surgery.
And it's interesting you say that, and I think, if you're willing to be my guest again, I would like to hear about the that part of the population, because I do, baby boomers are coming into the health industry. They are by far, at least in my research, that's been, they're the biggest generation in terms of coming into not only retirement, but also, that's going to be something that I think healthcare needs to watch for. And that this is a generation that's going to come into our health systems, come into our practices, and things that may necessitate care. And some folks may be, have they're not aware whether they have lung cancer or not, but and require screening. So I think that it's a conversation that I think is very interesting, and there's going to be more, I think, as time goes on. So I would love to invite you again, and just as a learning, of in that particular set of population, for population health. I think that's a very interesting topic. But in any case, how do we reach your practice? What is, thank you for the education, particularly for those of us that have family members that we are aware or need to talk about lung screening to them, and just an awareness of that education. So I really, really appreciate that. What would be the best way to reach you in your practice?
Yes, you can go to lumiri.com, lumiri.com. Our phone number and locations are listed there. I'm also on Facebook at Tiffany Schatz, MD, and I'm happy to have you call our office 215-695-2777. So most of the patients who I see are referred from other physicians. So I'm happy to see patients as a second opinion who have seen another doctor, or you can ask your doctor if you have a need for a referral to a thoracic surgeon. You can ask your doctor to refer you to my practice.
Perfect. Well, thank you so much, Dr. Schatz. I really appreciate you coming on for our Wellness Wednesday, talking about Lung Cancer Awareness Month. I think we really should also keep talking about this conversation, not just in 1 month, to be able to, get a little bit more increase, I think, in that arena. So I thank you so much.
You.
Thank you, folks. Thank you for our guests listening. And this is another Wellness Wednesday. Thank you so much.